Good evening and welcome back to the fourth part, the final part of introducing implants into your dental practice, four-part series. We will be doing more webinars. We're taking a week break next week, but from the following week we'll be continuing and going through a number of subjects of interest. If you have something that you want me to talk about in particular, please contact us, let us know. Without further ado, let's get started. Okay, so today we're going to be talking about complications, the elephant in the room usually. So I'm just going to share my screen so that we can get started. Okay, right. I will come back and talk about a number of people have been asking at what's available in terms of training and education, and there are a number of things that are available. So sorry, just going back to the first slide. A number of things that are available, but I will go into more detail at the end of this webinar as to what is available to everybody, whether it's accredited, non-accredited, experience, etc. But we'll dive into that a bit later, and I'll give you some details. Okay, so just a short introductions. We're going to be going over complications as a result of general medical contraindications, which just generally, we've covered this already, but I just wanted to bring light to it because it is important. Quite often, it's one of the things that people miss and then come back and things have gone drastically wrong and they could have been sort of avoided or managed at the beginning. It's one of the things that we quite often overlook. And I've given a list here again of the relative and general medical contraindications. Accidents, we'll go through accidents, events that occur during surgery, complications in general, and events that occur after surgery has been performed. Okay, so going through that, moving forward. Relative and general medical contraindications. Poor general state of health. We discuss ASI levels and classification. If you want to, please go back and have a look at your YouTube channel and connections, and you'll see a list of them. We have, I think, this week started sending out all the templates. I apologize for the delay. We wanted to add some additional bits of value in those so that you had a set number of templates that formed a blueprint for each one of those webinars, including this one. So you will be getting these two, and you can rewatch all of these on the YouTube channel. Uncooperative and unmotivated patients with adequate oral hygiene. Now, this is an important one. This is one of the ones that comes up time and time again when I'm asked to advise on cases from a legal perspective. And I myself have come into hot water with this. You know, I'm a firm believer in talking about, you know, mistakes that we've made. You know, and that's the first thing that somebody auditing your case or looking at your case, particularly by AHPRA or dental council, will look at to see if the patient is motivated. When I'm doing sort of very large cases, like the type of things where, well, on a SAP classification, for those of you that are familiar, it's been popularized by ITI, but I think originally was developed by the Royal College of Surgeons, Edinburgh, as a classification, simple, advanced, and complex. With the complex cases particularly, but all cases anyway, I need to prove that the patient is cooperative and motivated and has adequate oral hygiene, particularly when I'm doing full mouth rehabilitations. When people come in for a consult, we don't just get them in the next week, following week, and start putting implants into their mouth and a bridge, all on for what if you want to call it, we call it full mouth rehabilitation because I don't like copyrighted names. We have them in and they come in first for a consultation. They then come in for diagnostics where we take a lot of measurements, scans, etc., all the information we want to collect, including a very extensive examination involving 6-point probing chart, bleeding part scores, furcation, recession, etc. Sorry, going back there. This is followed by 2 other appointments where we review the oral hygiene. They get extensive oral hygiene instructions. At each of these 3 visits, we use disclosing solution to see their level of oral hygiene, and they're not really able to move forward implant treatment until it's adequate. And that's a safeguard A for the patient, because you're acting in the patient's best interest. Your duty of care is to the patient, not to their teeth. And also safeguarding you in terms of A, litigation, B, being brought up in front of a disciplinary. They want to know that the patient able to do that. With these cases where I'm placing a full mouth bridge, if the patient particularly is coming with periodontal disease, and that a large number of patients that have a full clearance have periodontal disease, then we need to make sure that we're putting a fixed prosthesis into the mouth, that they're going to be able to take care of it. And if they're not able to take care of that, they'll end up in the same situation they were in before they came to see me. And quite often, as I said, it's chronic, generalized, advanced adult periodontitis. So we don't want to end up there. Uncontrolled diabetes, again, 1 in 4, I was quite surprised to learn this, about 1 in 4, it's probably a little bit less, roughly 1 in 4 people with type 2 diabetes are in the community undiagnosed, because they either tend to not go to the doctor or be seen, they don't have signs or symptoms, or the signs and symptoms are at a level where they don't really notice them or affects their life. So you do need to check this. Sometimes if you're in doubt, this can be done with a very simple test. Bleeding disorders for patients. Okay, look, these are uncontrolled ones. I quite often get patients that are on blood thinners, patients that are on warfarin or many other things. And what we tend to do with them is basically talk to their clinician and discuss with them either stopping that for a short period of time or an alternative. Immunocompromised patients, the same with bone metabolism disturbances, and same with prolonged therapy and inadequate wound healing capacity. Tobacco, drug, or alcohol abuse is a difficult one, because usually you don't know. Quite often patients, standard thing is obviously most of them won't divulge, especially recreational drugs or even non-recreational drugs where they're addicted to painkillers. Alcohol abuse, unless it's severe, isn't really evident. So you need to watch for that, smell of ketones, their behavior and everything else. It doesn't happen that often, but more often than you think. And it has quite a significant effect on the body, especially alcohol and drug abuse, put them into that sort of catabolic state. And in that state, you don't really get implant integration, particularly if you're doing things like grafting. They tend to fail, or you're getting very little graft at the end of the procedure. Tobacco, we prefer patients not to smoke. I like patients to have given up smoking for at least 3 months before they have treatment. We do give them support. A lot of them tend to use Champix, which is prescribed by their doctor. If they are smoking, you can still treat them. It depends on how severe it is. However, you need to warn them of the complications and risks, and therefore make it their responsibility. Okay. So, with complication of implant treatment, it's implant success versus implant survival. Two very different things. Implant success is used to describe clinical conditions, ideal clinical conditions that usually have a time period of assessment. The standard is 12 months for implants, as well as the prosthetics. Okay. Implant survival relates to the time of evaluation of an implant, regardless of any adverse signs and symptoms, and is therefore differentiated from implant success. So, it could have 50% bone loss and peri-implantitis. It's still surviving. Okay, is it successful? Maybe not. Okay. Okay. So we've gone through that. So this is basically where we're going to be going with it. Okay. So in the two areas, ailing implants, will be ailing implants, failing implants, and failed implants. Ailing implants are implants that show loss of bone on an X-ray, but do not have any signs of inflammation, that should say, and are stable and not mobile. Failing implants are implants that have bone loss and signs of inflammation, but again, do not show any form of mobility. And failed implants are implants that have bone loss as well as mobility, and therefore no longer functional and require removal. These are usually categorized by layer of granulation tissue surrounding the implant, but not exclusively. Okay, and there's no way back for a failed implant. Usually, my view is if the first signs of failing implant, I would prefer to remove that, because what you don't want to do is end up with a situation with the failed implant. Lots of granulation tissue, you have to remove all that granulation tissue, creating a bigger hole, big arteriotomy. Then there may be insufficient bone for you to place an implant. So you then have to go to grafting. And it becomes sort of like, you know, a domino effect. You're also taking all that granulation tissue out. Do you really want to place an implant in there? You know, if it's failing and you can detect it early, quite often you can take it out. There's little granulation tissue, if any, and you can usually place a longer and wider implant, okay, because you're basically going into fresh bone. We often do this for, not for failing implants, but when we're placing implants in particularly poor bone, like a D3 or a D4 bone in particular, then when I first place the implant, we need to get torque. And when we're doing a full mouth rehabilitation, all the implants need to torque at least 35 Newton centimeters for me to immediately load them on the bridge, linking all the implants together. If we don't achieve this, there's various ways we do this, by repairing osteotomies, using more aggressive implants, etc. The old way was usually to take the implants right up to, on the upper in particular, right up to the nasal floor. In most cases, just crack into the nasal floor. So you've got bicortical fixation. I don't really do that anymore. And the reason that I don't do that, I haven't done for a long time, I leave it short because you don't really need to. It's quite invasive. And the implants integrate and you can do the procedure without that. But more importantly, if I've got space for an 18mm implant towards the back of a full mouth rehabilitation, which is slanted forward, I may place a 14 or a 16. And I'm usually placing at 4mm diameter. The reason I do that is because if that implant fails or I don't get that implant to torque, I will use a more aggressive form of implant that is longer and wider. Okay, so putting these together is basically a classification system, and the classification system that allowing to see whether an implant is successful or survived or not. The success optimum health has no pain or tenderness upon function, no mobility, less than 2mm radiographic bone loss for initial surgery, no exudates. Okay. I would even say the 2mm for is not really something that I'm pleased to accept, but that's sometimes what you have to accept. It just depends, we'll go into later, on the type of implant you're using, and you realize how important that is. Okay, satisfactory survival is no pain or function, no mobility, 2 to 4mm radiographic bone loss, and no exudates. A compromised survival, many have sensitivity and function, no mobility, radiographic bone loss greater than 4mm, but less than half of the implant body, probing depth greater than 7mm, may have an exudate history, pain or function. If you get mobility, radiographic bone loss greater than that, then you're basically having the failing implant, uncontrolled exudate, and no longer in the mouth. Okay, with implants with bone loss, we'll go into peri-implantitis. It's sort of not like periodontitis, where you can sort of arrest the disease, stop it completely, and get complete stability, in my opinion, in my hands. That's not essential. That's not completely true, but clinically in its application, it is. The likelihood of stopping it and having the implant survive a long time, the chances are lower, but we'll go into different ways that people have tried to bond bone back onto an implant or stop the disease, etc., and different ways you can do that in a moment. So the types of complication are surgical, biologic, Mechanical and technical. Aesthetic were related to augmentation procedure and related to loading protocols. Okay. With surgical complications, sorry, when we're going through this, the first number of slides that we're going to be going through theory. So don't worry about the fact there aren't a lot of pictures and other things, because the second half of this presentation is purely clinical cases. So I've just sort of dug up just things that I could find, some cases that are very, very old and when I used to do things differently. I'm not saying I don't make mistakes. Anybody that tells you they don't make mistakes anymore is not telling you the truth. I do have a very high success rate because I have certain set systems that work and that are scientifically proven and have good clinical basis. But do things go wrong? Yes, they do. It's just not what goes wrong, it's how you manage it. Okay. So surgical complications, hemorrhage and hematoma, we get this quite a lot. We get it for the full mouth rehabilitation cases again, and it can be somewhat unpredictable. You know, I've had the biggest guys, tough as old boots, you know, 6'5", 250 pounds, not, you know, less than 3% fat on them. They're like, you know, a strong human being with a strong constitution, and they come back with bruising everywhere. And then I have the smallest of frail patients in their latter years, and they have no real complications or signs or symptoms after surgery. When we do get, you know, the patient's lying down, especially when we're doing upper and lower full mouth clearance and full mouth rehabilitation all in one go, which is usually around about between the sort of 4 and 6 hour operation. Sometimes it can go longer if we're having to do simultaneous bilateral sinus lifts and simultaneous placement, and they may even go on for about 6-7 hours. So when these people are lying there for that long period of time and you're doing surgery, you're going to get bleeding, you get pooling, and that blood, the hematomas, the hemorrhage comes to the surface and manifests as what we call a bruise. You will usually find it under the eyes. That's where it tends to happen quite a bit, and obviously in the area around the mouth of surgery. Now, it's not of major concern and usually disappears. You just want to be careful that it doesn't track down the neck to the chest and to the mediastinum. And that's where you have to just be a little bit careful. That shouldn't really happen if you're conducting surgery in a proper manner and have good surgical skills. Neurosensory disturbances. Now, these again, with these can cause problems usually not by you actually going into a nerve. They're sometimes from actually pressure with a nerve. So what tends to happen, as I discussed, hemorrhage, hematoma, we know what to do, but with the neurosensory disturbances, you want to map the area. So if you've placed an implant, let's say in the 4.4-4.5 region, close to the mental foramen, but you're not on the mental foramen, quite often what happens is that compression from above the bone can compress on the nerve and cause this neurosensory disturbance. This manifests in a few ways. You can either manifest as a numb area, in which case you take, you basically map. So you basically press between with a pointed instrument, not something sharp that's going to go through the skin. So the patient can feel until they can't feel it. And then you keep doing that. And then you will put a pen dot and map that around and take a photograph. And then come back. I usually, if it's after the initial phase, I get them back after 2 weeks. And then after 2 weeks, if it's slight improvement, a month. And then after that, another month later. Usually any neurosensory disturbance will reverse itself in the first 3 months. And if it doesn't, the likelihood is that it won't ever reverse itself. So these things can happen. And if you followed good protocol and good practice, you know, compression is one of those things that's a complication. That's why it's in that consent. You know, you need to know about that. Quite often what also happens is that the compression of the implant above can sometimes have a trabeculae of bone that it pushes, that it's not associated to its surrounding, and it sort of drops down into, let's say, the ID canal. And again, usually within that 3 months, even if there is bone in there, that will resolve, and then you will start to feel that nerve again. Okay. Implant malposition. This is really from poor planning. You know, look, malposition is also lack of surgical knowledge and skill, poor communication between surgical face and restorative face, and poorly designed or manufactured guide. I'll work from the bottom up. With the guides, you know, look, you need to know how to plan on a guide. I was planning on a guide, so we've got leeway. Okay, so that you're not sort of within a millimeter of nerve, you're not within a millimeter of coming out buccally or lingually or palatally, you're not within a millimeter of a vital structure. You know, you've got some leeway each side, and you keep yourself safe. With poor communication, if you've planned things well and you've communicated to your technician well, you know, if you don't make your own surgical guides, you need to have a printer and setup. You don't need one. Part of the course that we're doing here and the boot camp that we're doing is so that you can plan on a computer and learn how to plan the guides. Now, look, you don't even have to plan them. They have clinicians that will plan them for you at a cost. You then approve that. They give you very detailed explanations of what's happening. There's sections and where they're hypothetically placing the implants, and they usually give a video too. We use 2 different ones, and one of them used consultant periodontist from Sydney Uni, and the other one use oral surgeons. You need to, the reason I suggest that you know how to plan is because unless you know how to plan, you don't know then how to critique somebody else's planning. So if that comes to you and just nod your head and say, yes, they've got a very bold statement at the bottom saying that the liability lies in you for accepting this and using this guide. Okay, it's not like, oh no, they gave me a guide that was inaccurate. And remember, it's in the name, it's a guide. Okay, the best bit of kit in your surgery, the best tool in your surgery is you. Okay, so eyes, ears, hands, that's what you were taught to do. And that's what we hope to build on if you come to bootcamp or you want to do one of our courses. Okay, lack of surgical knowledge and skill, the same. Learn. Take it easy, go slowly, you know, do things well and properly. Okay. The malposition, when it's buccolingual, what usually happens is that you either get a restoration that's got a ridge lap and is a cleaning problem, or you've got a prosthetic problem in the sense that sometimes the bone is just at an angle and you need to place it there to avoid structures. You know, you need to consider prior to placing that implant what the angulation is going to be. Because if you can add bone and create a straighter implant in an ideal position, that's probably the way to go. If the inclination is mild to moderate, that's up to you to decide because you've also got to look at the occlusion. Then you can place that because now you can have abutments that correct that. So if you've got an implant placed at an angle, you can have abutment that corrects that and makes that straight again. Ideally, you want forces acting axially, but you know that's not always possible, and there are complications to that too. Okay, so biological complications include inflammation and advancement surrounding implant soft tissue, dehiscence and recession, periodontitis and progressive bone loss, implant loss or failure. Causes of inflammation, advancement, disease around implants, bacterial load from plaque accumulation mainly, or poor oral hygiene. That's coming back to, again, the oral hygiene. Sometimes it's because the inflammation, advancement of disease was a loose prosthesis, including abutment or abutment crown, and then also retained cement. I prefer not to use cement retained crowns. Sometimes you have to, because as I mentioned earlier, if you've got severe angulation that's been corrected with an abutment, you don't have the liberty of having a screw retained crown because the hole will be coming out somewhere that's visible, or and usually it's in the anterior when you have there's alignments of those implants. Retained cement, terrible. You know, it's happened to me. I've missed it on my patients, come back, and it really does destroy things. It's really quite horrible when it's not where it's meant to be. Okay. And I've had bone loss, have had persistent inflammation and even pain. Patients where I can't find these things, you can't see on the x-ray. It may be on the palatal side of, you know, crown, and we raised a flap and hey presto, there it is. I can see it clear as day. Things feel like quite the fall. So make sure you've got a process where you don't have retained cement around it, and you check that thoroughly before you allow that cement to set. Dehiscence and recession is really about bone quantity, quality, and biotype. If you're dealing with a biotype 1 and the quantity and quality of bone is poor quality and very minimal quantity, the pressures of the implant causing recession and resorption and dehiscence are what happens. And as we discussed before in our very first webinar rather, biotype's important. You know, biotype 1 patients tend to have recession and not pocketing. Biotype 2 tend to have pocketing as opposed to recession. Biotype 1 are quite difficult type of biotype to deal with. And then it also depends on the bioform, the shape of the teeth. You know, if you've got triangular teeth, you'll have longer papillae and the large, more of a risk of having black triangles between teeth, which is just as important to assess before. Peri-implantitis, okay. Mainly from poor oral hygiene, a history of periodontitis, diabetes, okay. Remember, peripheral circulation of diabetics is much poorer. Healing is impacted. You know, a lot of the diabetic patients, I generally give 2 grams of amoxicillin pre-surgical and usually an anti-inflammatory, depending on their medication. If they're allergic, then we give them an alternative, usually clindamycin. A lot of my patients are under sedation, so I leave that to the anaesthetist. We prefer to use an anaesthetist rather than a sedationist, just for safety and really to have a broader scope. The diabetics, if they're IV, then we can't really give them pre-op anyway, so we have to put it through IV. But if they're attending as a patient not having IV, I prefer the diabetics to have a course of antibiotics for a week before they have surgery, and then continue to be on antibiotics. Everybody else, a loading dose an hour before, and then antibiotics for a week after. Smoking, we have discussed. Excessive alcohol consumption, we've discussed. And implant surface. Okay. So there are a number of ways that they say that you can basically attempt to cure, well, to basically perform alveoplasty. So putting bone back onto an implant, building bone up, okay? Quite difficult because the surface of an implant is designed microscopically. If you look at it, it's like a large honeycomb structure on the surface because it's designed for osseointegration, for bone cells to grow into that, okay? So to become one. If that implant surface is exposed, then all those millions of tiny little caves that bone's meant to be in are tiny little caves for millions and millions and billions of bacteria to live in, and to eradicate that is quite difficult, okay, on the balance. And as we all know, that bacteria are opportunists. So the surface matters. I like the fact that the implants I use are Straumann implants, and I like the fact that they are SLA surface. It's a surface that's been tested for a very long time, been improved and improved upon, okay, and is a standard. And I'm a firm believer in not gilding the lily. You know, I don't want to use a unique surface to a implant company that is really a selling point for that implant. Why not use what everybody else is using and it works? You know, keep it simple. I don't want to go back and replace implants X many years later. Now, the other thing about the implant surface now, the modern implants, they tend to be rougher towards the bottom, so for osseointegration, and they tend to be machined at the top. And what that means, around the neck of the implant, the bit that's going to be coronal towards the surface, the top of the bone, and towards the tissues and the oral interface and the outside world and saliva and bacteria and food and everything else that goes into your mouth, are the surface and those is machined, so it's much smoother. It doesn't have that heavy sort of porosity or for things to grow into, because that's down towards a base to create stability or primary stability and osseointegration. So that the bit around the neck, the machine part of the implant, means that it doesn't really require as aggressive osseointegration. And by doing that, you have less likelihood as an element of protection from a peri-implantitis. However, that's only as a default. Ideally, you want to observe all principles to avoid peri-implantitis. Move on. Implant loss or failure. There are two types of implant loss. One is earlier. Implants failure occurs before the implant has had a chance to osseointegrate, and is often caused by infection, movement, or poor wound healing. Late implant failure occurs after the implant has been restored, and is often due to peri-implantitis, progressive loss of bone, or occlusal overload. With the early implant failures, it's fairly obvious. We've discussed that. With the late ones, it's usually occlusion and peri-implantitis, as it says there, but because with the occlusal ones, you tend to notice a saucer shape on the X-ray, and that's a firm indication of occlusal overloading on an implant. The peri-implantitis, bacteria are not uniform and discriminate, so they tend to just munch at the bone or cause bone metabolism in a different way, so it tends to be irregular. Okay. Mechanical and prosthetic complications: screw loosening and fracture, implant fracture. Implant fracture hasn't really occurred to me. It occurred in my practice. I have heard of that happening. I think it happens when people are using implants that aren't tried and tested and don't have a long legacy. And there's a number of big companies out there. Stramlin's is the only one. As I said, they're supporting this course, and I'm not batting on about them because they're supporting the course. They're supporting the course because I asked them to, specifically because I use the implants and I love them. And I think they're the best implants I've ever used. And I don't get any problems with them, but that's in my hands. So you decide what you want for you. Screw loosening and fracture is not really a big problem. You can retrieve screws, you can replace screws, abutments, and everything else. And to be honest, I'd rather that happens. We use multi-unit abutments on implants in full mouth rehabilitations or large complex cases, but now I'm sort of tending to use multi-unit abutments rather on short spans and bridges, because the forces are transmitted to the multi-unit abutment. The worst thing that happens is the screw loosens. Very worst, it might break. You can replace the multi-unit, you can replace the screw, you can just tighten those. The forces are then not transmitted fully to the implants. You don't get bone loss and then having to replace implants and bone grafting. Aesthetic complications: poor assessment relating to high expectation from the patient, high smile line, not small line, sorry, via type 1 periodontal soft tissues, insufficient bone quality, and poor bone quality. Phonetic problems: these are in the aesthetic zone and for full mouth rehabilitation. With the aesthetic zone, in that area, when you speak, you form what's known as an anterior embouchure. You'll see people that play wind instruments use this, where they build pressure around that front area. You need those front teeth and that seal to do that. You also need that for speaking. There is a risk analysis that you can go through quite simply, very simple tool to use. We do go through that in our courses, and we're quite I'm quite on that because I like that tool. It's really easy to use, quite fun to use, and it literally tells you exactly what to do. With full mouth rehabilitation cases, the problem tends to be, if you look at, let's for example, an upper jaw, particularly, the teeth anteriorly, pretty much from canine to canine at least, are not in the bone. They look like they're on the bone, on the front of the bone, like they've been literally stuck onto the front of the maxilla, and there's a thin coating of bone on the front, so you can almost see their shape sticking through. As they get to premolar, they start to be in the bone, and the molar, they're right in the middle of the ridge. So when you remove those teeth and you place implants, you're obviously placing in the ridge, so you're automatically moving that arch inwards. Moving the arch inwards gives the tongue less space, and that has problems with phonetics. So often we try and keep that towards the outer part of that arch. Okay, so it's not just about placing implants. There's full mouth rehabilitation is a very complex subject, but we have a training course. That's a 4-day course. I think it's 4 or 5 days, I forget. And then we ask you to come in and assist a number of times before you even attempt one. There's a number of factors that you have to consider for every case. I think it's 53 or 54 factors that you have to consider, and they're important. You have to consider every single one. But once you get it down, then you know what's happening. And with those phonetic cases, sometimes we can't predict in our consent, but we do everything we can to try and create that space. So with placement and loading protocols, it's immediate implant placement. That's a whole subject by itself. We won't go into that now. I like immediate placement, but there's times to place and not to place. Position of the implant is poor, loss of bone marginally, loss of soft tissue around the implant, poor aesthetics. That's usually due to poor placement of implants, because as we said, we build plan from the top down, build from the bottom up, or emergence profiles, or people haven't considered platform switching, which we went into on the last webinar. Poor primary stability and implant failure. Look, primary stability is key. I keep batting on about that as well every time we have a webinar, but it's very important. If the implant isn't stable at the beginning, it's never going to be. If you put it in and it doesn't have primary stability and it's sort of moving around, that implant will not integrate. Primary stability is key. Okay, it's the first thing that you need to have. Even if you have primary stability and don't have other things, quite often you can get an implant that survives against the odds. But if you don't have primary stability and you have all the other things right, your implant still is not going to DLC integrate. I can tell you that now. Okay. We're nearly into the sort of more exciting stuff. So we've just been through all of that. The other part of that, the bit that we have not been through, is implant design. We have cantilevers. When you join 2 crowns to 1 implant, I don't like doing cantilevers. Do I still do them? I'm doing not an implant actually. Yeah, I'm doing one recently, and that's just as a massive compromise. I think it's going to be a temporary measure, but the patient understands. Okay. When you join 2 crowns to an implant, when you want to cantilever, if you have to cantilever, you want to cantilever forwards, not backwards. And the reason that is as you get towards the back, particularly in the maxilla, as you get further back in the maxilla, you get poorer and poorer quality bone. The worst bone in the mouth is posterior maxilla. But more importantly, as you get further back, you're getting closer to the TMJ. And where do you put a nut in a nutcracker? Towards a hinge. That's where the highest forces are. So the forces are increasing as you get closer to that hinge. Okay, so you want to stay away from that. With shear forces, what I mean by shear forces, you have compressive forces that come together, and then you have tension forces that pull apart. Shear forces are these forces, okay, and then tend to occur on lateral excursion. So for example, if I'm replacing and there is a section we go through. If you want to know about occlusion, please come and talk to me. As I said, I sort of spent nearly 5 years going to Dawson and Pangy in the States, in Florida, just learning about occlusion only. And it's a vast subject, but we've sort of managed to condense it for implants at least, and even restorative and other things that I do teach aesthetic dentistry as well. Shear forces are the one thing that implants don't like. When we're replacing some premolars, for example, I will make sure that buccal cusp isn't really long and pointed. It's quite rounded and shallow, so for the actual jaw to get out on a lateral excursion, it's very shallow, and there's a shallow guidance. You don't want the jaw to have to steep all the way down and come under that tooth, and that's where you need to be careful of shear forces. Okay. So we'll just go through some cases and things that just popped up, and I didn't on randomly. It was a good way to do it. This is a patient that came to see me, and we'll go through a few things. Quite a long time ago, very long time ago actually. This one had some, I think, They were temporary. I think they were sort of not temporary crowns. I can't remember. I think the material that they used was Gradi, and I don't think it's around very much anymore. It's a softer sort of composite style material, often used with crowns. Very good with the pink as well. The problem with it was it had a lot of staining. It did collect a lot of stuff, but it had some flexibility in the material. And what they were tending to do is, if you have a very hard material like zirconia, and then you've got a hard abutment and screw and hard implant into bone, the theory was the forces would just go through the whole thing and transmit it to the implant. So what happened was, if this sort of crown could absorb some of those forces, almost if you imagine on a microscopic level, like a squash ball, okay, it was acting like a periodontal ligament, not exactly, but in theory. So you're building that flexibility or that suspension into the crown, okay? So I think that's what these are. You can see it there too. Now, if the patients came to see me, I would definitely make sure that none of these things around all this build-up of hair wasn't there. But look, looking at that, the height sort of seems to be quite good. If I go back to that other slide, the height seems to be quite good, but it's the width. Now, if we place an implant in this area and try not to graft the bone and place along there, which can be done, you're going to have an implant, but buccally you're going to need to extend out, and you're going to have a ridge lap, and you're going to have problems where you will get food stagnation and cleaning problems. Okay. Also, in that area, that bone is quite thin, and the diameter implant you're going to have problems with too. So what did we do here? Okay, so there you can see the height is actually quite good. The tooth behind is actually an implant. You know, we've taken that back. You can see the ridge going inwards. So we basically, we'll go into this, but I can touch on this anyway. This is a bit more advanced. When we graft areas like that, because that area, I wanted to have a very firm and stiff barrier, collagen wouldn't have done there. The amount of bone that I was adding in that area to get a good result on the width, along with a keratinized tissue graft and connective tissue graft, it was going to be difficult. So in these cases, what we tend to use, I prefer to use, I don't like using blocks or using trephines to take great big holes out the back of the jaw, because this donor site has a risk of morbidity, and then you're creating a problem rather than fixing one. Okay, is I prefer to use a bone scraper and have patient's bone, autogenous bone, and then use donor bone. I tend to use an allograft at the moment. And what I will do is I'll perforate the surface so there's perfusion and blood coming through. We'll mix, I will put a base layer of the patient's bone, milled bone. I'll then do a 50-50 mix, and then do pure graft bone on the top. I think in this one I used, it was a xenograft. I can't remember exactly which, but then the membrane going on top at this time, to make a stiff membrane, because you want stability of the graft. It's like implants, for them to survive or get good graft, you need stability. So we used a stiff membrane that you need to remove, is not resorbable. Excuse me. With this particular one, with the shape of the defect, I used a reinforced membrane with a titanium reinforcement. They call it a spider. You'll see in a moment that particular membrane. There it is. It's a bit bloody because we've tried it in. You can see around the edges I've rounded it off, except for this bit here, and that would have been rounded as well. The sort of arrows you can see in it are the actual titanium inside it, and it allows it to bend and maintain that shape. But you can't just put that in. Once it's been put in, you need to then tack the membrane to get it secure, and then get closure. I think we can go through steps here. Okay. This would have probably still not been tacked and tried in. You can see there's a little bit of membrane, sharp bit pointing out. When you use membrane, they usually come as squares. Cut the corners off, round them. Nature doesn't like sharp things. Help it. Give it a hand. So that's the membrane itself. With these membranes, you do get a lot of dehiscence of the flap. So they're one-way permeable, and sometimes if you get that, the idea is to leave it another 30 days, get the patient to clean it, keep it clean, and then after 30 days, which is not ideal, I would then take that out and close over, and we see whatever bone we get. Here we're using PTFE sutures, and they allow for expansion and swelling in that area, particularly with grafts. I like using these sutures. And I think the tooth behind had a little bit of bone loss. It wasn't at the point where you saw sort of tissue around it, would be like, oh, well, is that recession? What's going on there? That wasn't recession. The implant was actually much lower down. That was actually quite a long abutment. So therefore, you know, looking at that, I think we did take that off. Did we take that? No, we investigated. We didn't take it off because it wasn't cement retained. Sorry, screw retained. It's cement retained. And because the implant was subosseous, we left it. It just had, I think they placed the abutment. It was that implant wasn't done by myself. I think they placed the abutment quite deep, and I think the abutment junction was subosseous as well. It's a little bit strange, but hey ho. But in the long term, what's happened, the bone is remodeled to that junction of the implant. And this was the X-ray 6 months later. And we managed to get a decent amount of bone. Look, you can see what's called the spider, the titanium and the mesh. There's the tacking it on the outside. There's that implant at the back, and you can see the bone level's still about there. If you're, you know, and although the X-ray didn't show it, it's probably more about there. The only criticism is more about that junction. The only criticism I had is maybe distally a little bit, but if you've got good tissue seal, there's no pocketing or anything else, would I be justified in taking that implant out? No. But, you know, I thought that was a fairly good result. Okay. I wouldn't treat this patient with implants straight away, you know, and you can see why. Look at the amount of caries. At the time we did, okay, things have changed and the way we think has changed. And you can see, remember I said to you before, have a look. She's probably more like a biotype 1.5. She's got the arches haven't fully expanded. There's wear, there's caries on the most easily cleanable surfaces, the buccal surfaces, the buccal lesions everywhere, caries between the teeth, and you can see plaque and build up. Let's go. Okay, so the vast majority of her teeth were terminal. Okay, so they are either periapical lesion, required root canal treatment, non-vital, broken down, etc. The reason I've shown this slide is with these angulated implants at the back, these are basically, this is the ridge after the teeth have been taken out, an alveolectomy has been performed. So we've taken, cut the jaw down so that when the patient smiles, the bridge is not visible. So that's the point at which the bridge starts. 2 straight implants with full mouth rehabilitation when using 4 implants. I don't always use 4, sometimes use 6. I prefer to probably go the way of 6. When you, not always, we'll talk about that, where the 2 middle implants aren't really, you know, make any difference. But these are sort of placed probably around just the lateral of the lateral incisors at the front, and at the back you can see they're pointing backwards. Now the implants sort of point at the angle at about 30 degrees, but you use a multi-unit to correct that. And in this case, I think the angulation was more than 30 degrees, so you've got these backward pointing implants, which is not the end of the world. This is designed so that it's joined together, so it doesn't have the same principles as single implant acting axially. However, what does happen, I think after we stitched it all up, you can see it there, you can see them pointing backwards there, is that the problem with that is that the old way we used to do it was we fixed these cylinders and we'd put holes in a denture and put it around there and get it into the bite, and then put some structure to fix it into place, put a wash underneath, then unscrew the whole thing and send it to the lab so they could finish it off. And it made even the prosthetics more difficult. There are the cylinders, you can see them pointing backwards there. The front ones aren't too bad. And hey presto, those giant holes at the back. Probably looking at it now, probably would have designed it so that if she had sufficient bone at the back, just place straight implants, wait for that to angulate them. The angulation would have been less, and just using, therefore, then using, and also knowing where the hex, the internal hex of the implant is, and we have indicators. Strands have little dots and sides that show you where it is. And now when we do that, we finish with that on the buckle, so that when we put the 30 degrees multi-unit in, those point straight down, so that as do the front ones, so that they have a similar path of insertion going in. And we don't do this type of thing anymore anyway, because we just basically fully digital, so we scan everything. And if you want to come and have a look at this stuff and what goes on, come in, contact us, just give us a ring, send us an email. Don't be afraid. No one's there to judge you. We're there to help you. Come and have a look. There's no obligation. You know, it's free. Come into the surgery, book an appointment with Millie, and ask her who coordinates everything, and who I introduced through slide at the very beginning of the first webinar. Come in and have a look. Come and have a look at some procedures. Come and see what we do. Come and look at the workflows. Have a go at using a scanner. You know, have a go at a few things. Come and assist me if you like. Okay. Invitation is open. Okay. In this case, patient, it's the 1-1 recession. There's a few other things going on there. And again, look, you know, I treated this case at the time. This is a really old case too. And would I have treated it now without that caries being restored, and maybe looking at the back, getting some stability? No, I wouldn't have. As you can see, there's the 1-1, got recession. It's got a nice biotype 2, really thick tissue that's acting in our favor. The bioform is square or maybe rectangular. The teeth, so minimal papillae in between. So again, helping us in reconstruction and moving forward. Okay, that's with flap elevation. I think that was joined as part of a bridge, so they've sort of joined it together, and you can see I've sectioned it here. And you can see the root underneath once I've taken that post core out. I hate post cores. Don't do post cores, please. Stay away from them. And only do bridges if you really have to. Learn how to do implants, give the patient a denture, go and learn how to do an implant, come back and give them an implant. It's much better. The other options don't contend in terms of statistics and survival rates. And the luxury of the actual restoration, you know, people use it and the enjoyment they get from it, as opposed to a denture, a bridge, or anything else. Okay, so once we took that out, that buccal bone probably went as I tried to extract it, or maybe it was intentional, or whatever it may be. It may have been just the fact that it's infected, but I think it's more likely that I didn't intentionally want to lose that buccal plate, because you usually try and preserve it, and it was my fault we lost it on extraction. This was a layered technique, and I know we used a xenograft with this one, but similar thing that I discussed before. We did a step-by-step approach with the layered technique, which I've discussed after doing it, and that was this surface layer of just pure graft. That's my membrane. There's a tap for the membrane. This is a collagen membrane in this on this case, and that was the patient all stitched up from it. Okay, so that was basically how we resolved that complication of having that high gum line and gingival aesthetic line. When we come back to this, we would have probably seen where we had bone, and you know, the bone, soft tissue is the issue, but bone sets the tone, and the soft tissue will lie depending on how much bone graft we had. If we didn't have enough bone graft and didn't get what we wanted, we'd still have an area of defect. This one, I think, after the bone graft, we did finish with we did need a connective tissue graft, and we needed to do some work with the keratinized tissue. Okay, and that's with a temporary restoration in place. Okay, this patient attending 2 implants placed has been there for a while. You know, as I said, survival versus success. Would you say these are successful? I don't know. I'd say they're pretty successful. Okay, although they've lost bone around them, they've probably got an element of periimplantitis. They were actually super clean. They've been seeing a periodontist, this guy, and he's just been having everything cleaned. So they were a lot cleaner than I thought. Now, one of the ways that people think that they can resolve periimplantitis, just off at a tangent, this is actually about something else, but I'll show you in a minute. Is one of the systems they used was to basically put the patient on doxycycline, expose the site, use what you'd use a bit like a gingival dam you use for whitening. There's something on the market like that you'd actually put onto the bone surrounding the implant, so you protected the bone. You'd use a citric acid preparation over it, and then the doxycycline over it. And then you would graft around it. Quite often, they'd use prep and emdogain like you do for alveoplasty onto a tooth. They tended to have the highest success rates in comparison to not using them, but still not, you know, on the level of success that I would think I'd want to bring that into my practice. I have much better success with emdogain and prep, which is wonderful materials, and you should really check them out. With teeth and building bone into that area, sometimes I'll use emdogains after watching a recent study actually at ADX, using that just within bone grafting. Okay, so in this case, patient didn't want the implants out. They had stable, fairly stable oral hygiene. And looking towards the back, you can see on the top, our top right, the patient's top left, the pneumatization of the sinus has gone down, bone has resorbed. Okay. Initially, my inclination was to talk to the patient about possibly, you know, if they wanted to remove those implants, to graft the whole area and remove that tooth there too, and give them sufficient teeth in that sort of 2.2, 2.3, 2.4, possibly 2.5 area. The alternative was to perform a sinus lift. The reason that the sinus lift is complicated, if you look at the area there, that white line is a septum. So we have to actually go in through one window and another window on the other side, lift the membrane and work our way. So you've got two windows, you have to go in and work your way around to the other window, almost like a semicircular shape, a cave that you have to work your way around, which sort of takes some time and skill to do. Okay, but you know, if you use basic sinus principles, you know, you'll get there with time. So you can see that septa and that break there. So that was the other two windows we created. You can see a bit of membrane there as well. I usually like to leave the windows there. That was the closure post-operatively. And again, you can see those two implants towards the front. They've placed them sort of palatally rather than pointing towards front. I don't think great placement, even with the bone. I probably thought about maybe either grafting the bone or angulating the implants to a better position. And you can see you've got a sort of ridge lap effect. And they almost look like two little chairs to sit on. So, you know, they've still got, the dentist fortunately has got some temporary cement in there that's been in there a long time. And so it's giving them access to that area. I think that bone loss has largely been due to occlusal forces as opposed to periimplantitis. It had that dishing shape. Just go back one. You see it's got that curved dishing shape, which is a little bit irregular. So anyway, we have that, we went to that, this is where we started with the hole there, and this is where we finished. That's with that area filled with bone. Okay, so then allowing us to place implants back further. I probably still would have preferred the patient to have lost those front two, because I know that we'd have to come back to them, but it's their decision. You give them the options, it's up to them, it's not up to you. And then just really going from there. What you see isn't always what you get. Again, complications with just a simple lateral tooth. Got a bit of a cross bite going on there, but if we look going forward, that situation, if I look at that at a glance, that actually looks pretty good. You know, slight buccal loss. The height is excellent. I think, you know, if we were able to maintain that for a tooth, if you look at the gingival aesthetic line on the other side, I'd be happy. Okay. There again, see, it looks sort of like the ideal I want after a graft of soft tissue. But sometimes what you'll find is, particularly in type 2, severe type 2 biotypes like these, they form a lot of tissue, and that connective tissue can be bulk and make it look like you have a bone in the area. But even on the buccal area, I wouldn't be displeased with that. Okay. If we look forward from there, once I raise the flap, you could see that things weren't as they seemed. It was a lot higher than I thought, and the buccal wasn't as completely wide. In this case, I think I initially used not even a pilot drill, like a pin drill, just to get my orientation where I wanted it. At this time, I wasn't using guides at all. Guides were available, but they're nothing like the accuracy they had now. They're impression-based, not digital. We were sort of working with expanding materials, including the models themselves, and then inaccuracies. You know, anything between 5 and 10 degrees inaccuracy with an implant that's, let's say, 16 or 18 millimeters long. At the tip of the implant, that's a difference of sometimes a whole centimeter. You can end up anywhere. Okay, so I think the next slide is with the prep drill, and then the placement with a bit of bone augmentation. So you managed to get a decent placement. Following placement, return, and the first radiograph you got is after with bone grafted implants. Come back and have a look, and usually I'll use an ISQ machine to check its stability and see if it's ready. I do that for all implants. We used to check on placement to see if I only check on placement now if I'm in doubt about the primary stability. But I usually check afterwards once we expose the implant to see if it's ready. The next picture along is with an impression coping. We don't use those anymore, use scan bodies. And the final one is with the restoration. And you can see, I'd say even now, I'd be pretty pleased with that these days. And this was probably about at least for 15, 16 years ago, this one, I think, or maybe a bit longer, actually. No, it's a bit longer than that, maybe about 20 years ago, this particular one. Okay, so moving forward, more complications. You know, what would you treat then, treat now? Look at this. Okay, would I take this on? Would I take it on the same way? This time when I did this, I think I did a bone graft to try and get back to sort of turning a complex case into a simple case and not having the complications. Because the rest of the teeth are pretty good too, other than the canine on the other side, I'd probably go the same way, but I would probably attempt to go bone graft in a different way. And I would be more likely to use a mesh as well. I'd also question the prognosis of the 2-1 and discuss with the patient the likelihood of possibly losing that if we didn't get bone buildup. In this case, we did. And I think this is more luck of the draw with the sort of techniques we were using then. We were using good sound techniques, but, you know, we weren't getting the success rates we're getting now because things have developed. When you raise it, that's what you've got. That's what you're working with. Okay. You're missing quite a bit of bone. I definitely would have used prep and end again in these situations. That was a build-up. Again, layered technique. I don't think my technique with that has changed for a while. Because of the defects, soft tissue defects, there's a fair bit of stitching that we had to do to achieve that. That was the offending item. And that was with the gentleman with a temporary restoration. And 6 months later, I think we got a pretty good result. That entire area, nice block of bone. The 2-1 was still vital. Okay, we did use, as I said, Emdogain in the treatment of that area. And if you look at the rest of his mouth, it's pretty good. There isn't some excessive area or anything else. The canine on the other side, funnily enough, even with that recession and everything else, was still vital. And although it looks for dark around it, that's not radiolucency. That's just the OPG, but I was quite pleased with that. So we then turn something that's quite complex, that could have a number of complications, into something much simpler. Okay, as I said, when you have bruising post-operatively, what tends to happen when we do alveolectomies, particularly where we get the bruising, and you see the pooling here around the eyes, around the mouth. This patient was actually treated on, was treated last Wednesday. Okay, and I actually saw her today. This morning, because we print our provisional bridges. So she actually had the bridge fitted within sort of 24 hours. Sometimes we fit it the same day, but she wanted to go home, and she was coming back for a second scan because we were refining that provisional bridge, and we get a designer, we print our own bridges for them. But this is the type of thing you get. So they all get swelling. Not many of my patients get bruising, but I do see this. Okay, this is sort of par for the course for me. We do everything we can to try and reduce this, but you know, this is what you deal with when you do what I do. Okay, so coming too close to a close. Okay, this gentleman had his implants placed abroad. Okay, the reason I put up this side, you can actually see, you can sort of vaguely see at the bottom all those little cylinders sticking out of his jaw, just at the crest. They are implants. And the ones at the top, you can see that one clearly on the top left, and you can see sort of mid and even a bit on the top right, the threads of the implants, because they're not even in bone. This was a bit of a disaster. He actually came to see me for full mouth rehabilitation and decided that he thought treatment as a general, not just me, in Australia was too much for him. So he went and bought and had it done. He was then stuck. They didn't actually even complete the treatment. He was then came back, and he was intended to go back to the treatment completed, but then the pandemic situation came along, he was stuck, and then he sort of came back to see me reluctantly because he felt sort of ashamed and embarrassed that he needed to see me, and he gone and got this done, and he suspected something's wrong, because I don't think he came straight back to me. He probably went to a few clinicians, and most people didn't want to touch it with a barge pole. I've made a career on treating everything that nobody else wants to touch, and these sort of bread and butter to me, but that's sort of how I learned my part of things, and I quite enjoyed these cases. It's not it's totally complete, but I will show you once we have completed this case. But I'll show you, excuse a radiograph, that's not mine. That was one that he sent me. And when we actually, I've got pictures of this, which I will actually maybe, I'll see if I can get together for the next webinar, even if it is or not on this, I can show you what we did with this. But just about every single implant was sticking out above bone, is superosseous. They had lost bone. I didn't see any real theory, maybe at the bottom of what they were doing, but they hadn't completed the top either. And then they decided to perform 2 sinus lifts, which you can see, which aren't bad, to be honest. You know, pretty good on the sinus lift level, but on everything else, 10 out of 10 for effort. But you know, I really can't say they're winning with this. So in the end, what we ended up doing, we actually took out all those implants, which are fine, so they're half integrated, and he had just basically holes everywhere. I did place implants at the same time. I placed 4 at the top, 4 at the bottom. He came back and we placed another 2 at the bottom towards the front, because we couldn't get the anterior posterior spread we wanted. But I will put up some pictures of this. So, you know, again, problems of travel tourism, we get a lot of complications from people traveling abroad. This lady, lovely lady, artist, she, those 2 implants you see, which are actually 2.5, 2.6, have been placed directly into the sinus. The difficulty here was that the only thing stopping them from migrating into sinus were those two, for want of a better expression, restorations, okay, of sorts. I don't know, God, don't know what they are. Anyway, if I was to remove those, there's a danger of the implant dropping into the sinus, then I'd create another problem. I didn't perform the sinus lift myself with this one. I actually referred it to my Max Flax. Okay, I didn't want to take this on. I could have taken it on, but I still want to take this on. I could feel that if this were pear-shaped, there was sort of litigation looming. Patient was already annoyed and upset, and if whatever I was going to suggest to try and fix it didn't work in my hands, I think that would then ended up being my problem, as opposed to the previous dentist who placed these implants directly into the sinus. So they're completely in the sinus. You'll see that in, I think, the next slide. There you go. If you have a look there on the top there, they are completely within the sinus. There's just a neck of the implant being held with a bone, and I wouldn't be confident on removing that dropping in. But in the end, what we did was I raised the flap. We used an instrument to grip the implant because we could see the neck. And considering that it was going to be sinus lifted and grafted anyway, I had the liberty of removing a bit of bone on the second implant to be able to grab that neck, so that when we basically unscrewed those crowns and took them off, I had a firm grip of that implant in place. And with the smallest of these, we were able to ease those out. Okay. This is, again, this is peri-implantitis. These implants are going to be replaced. These implants had very good bone levels. It's taken sort of at an angle, so there isn't as much of a disproportionate balance between the crown and the implant of the I think it's the 1-4, which has a crown on it. This is the angulator, I think it's about 50-50. But this was like surviving for a while. And the patient came to me quite a few years later, and this is what ended up. And he had a loose crown, and he came in to see me, and when we had a look at it, it wasn't really loose crown that was a problem. That is purely perio. The thing is that I look back at the notes, we'd assessed the patient fairly well, not as thoroughly as we do now, but it had deteriorated over time. In this case, I would just take both implants out. I'd look at talking to the patient about the prognosis of that root-filled molar too. Because if I'm going to graft the area, that's probably going to act as a hindrance. And if it had mobility and graft the entire area, come back to it and see where we're at. And also warn the patient that we may also need to do a sinus lift to have enough bone. I'd probably then do 2 implants and an implant-based bridge, or possibly 3 implants based on what the patient would want. This was sent to me. Again, this is, again, you can see they thought this is peri-implantitis because of the angulation. It's not. This one is definitely occlusal overload. You can see the cupping underneath, and this patient was abruxis. But not only that, when I had a look at the restoration and the emergence profile was huge, and the forces on the implant were quite large. It also, the patient had lost and had deteriorated anterior teeth that kept on breaking down. So it turned not even into canine guard, into root function. Most of the load had come towards premolar and backwards. These again were occlusal overloading. I think this is more because there's almost a mini cantilever built into the teeth. The implant is not central to the prosthesis because of where the implant is being placed. And they sort of, you can see they're front heavy, and I think the forces on them acting like a lever has basically caused bone loss around them. They're not particularly long implants. I'm not sure what these are because they weren't placed by myself, but we're replacing them. I think there may be 6 mil implants. I prefer not to place 6 mil implants. Only time I place those if they may be part of numerous implants in a bridge for reinforcement, and that'd be a larger bridge. But I prefer not to. I like to place implants at 8 mil or more. I usually try and place the longest, widest implant I can within reason. And finally, this is another implant not placed by myself. This is poor positioning, poor length and width of implant, poor emergence profile, poor occlusion, poor everything. You know, you can't even clean this thing. You know, this is sort of a disaster on many levels. And again, in this case, if we remove, graft, come back and place an implant that's central, with good contacts, easily cleansable, good emergence profile, and have to make sure that the implant is placed nicely subosseously. So coming back to what I was discussing at the beginning, we have a number of courses, number of things running. The webinars will still be running. We're having a week break. Please let me know webinars that you want to do. The boot camp, we were sort of trying to run at the beginning of December. We've had a lot of people saying that they are obviously coming out of the pandemic and wanting to be working. They're going to be working quite a bit. And is it a possibility that we could do it early next year? So that's what we've decided to do, which means that, you know, you can get back to work, get back on your feet, and have time to come to the boot camp and enjoy it and not be stressed. People who are interested will need to know now. Please let us know. I am asking you to let us know now, because once it's full, it's full. We're not going to be accepting other people, and there are a limited number of people that come on. Hands-on clinic, as I said to you, come to the clinic. So these are the things that are training options you have. You have the webinars, keep going to webinars, share that with your friends, invite people. You're creating community. It helps us, helps you, everybody else. The more people we have, the more things we can do, the more events we can do. Boot camp, same thing. Come along, come and learn extended skills, learn how to. At the boot camp, you will be learning a lot of things. We'll be going through everything we've done for webinars in a compacted form, because I want you to watch those and gone through those, and you've got the templates and blueprints and everything else. But we're going to be actually putting those into live action. So you've got the templates and blueprints. We're going to be taking cases and going through them all the way through, okay? So that you can then take a particular case, and I'll tell you about the medical history, this, etc. So all those templates, we're going to use them. So use them again and again and again until it's second nature. You'll also learn how to plan digitally on software implants, how to plan them, and how to even create a guide digitally, whether or not you print it or not. You know, that can be handed over, and then how to use that to place the implant. So realistically, it's a summation and a boot camp of you instantly introducing implants in. Well, not only that, if you come to a boot camp, you have mentorship from me. And if you want me to help you, or you want to come and place your first implant at the practice, and you want to bring your patient, you know, we're happy to assist and help you do that. We're happy to give you mentorship ongoing. Okay, hands-on clinic, come and experience some dentistry, some implant dentistry with my patients. You know, we obviously just need you to talk to Millie so that you can come in, and we can book you in, and of course we have to have the patient's consent for you to be there. We like to have no more than 3 people with a patient, because then you can't see, it's difficult, etc. And it's first come, first serve, and you have the opportunity. I don't know many other dentists that are willing to, or able to offer that, or willing to offer that. And if you're spending time there, etc., I'm quite happy to even give you a feedback form. We can have it as a teaching session, and therefore you can get CPD too. So you can come and learn and get CPD for it. Okay, so what do we offer in terms of accredited, internationally recognized qualifications? A certification. Like, look, the certification is a 1-year program. Okay, so the diploma, if you carry on from the certification and do a second year, you get a diploma. And if you carry on from that and do a 3rd year, you get an MSc. You don't have to do them consecutively. You can do 1 year and have up to 2-year break in between, okay, and come back to it. And some people just do the cert, start placing implants. They're happy, don't want to come back to anything else. And most people do the diploma because they're happy with that and they're learning to a higher level, bone grafting to a higher level and other things. And some people want the academic qualification of an MSc. Come and talk to us about that. We are now open for registrations for 2022. Again, there are limited numbers. We'll be starting sort of middle of the year next year for the actual course. With the certification diploma and MSc, it does require an interview because it's a university course. I will be at the interview, so not to worry. I've got your back. I'm sort of representing with you, and Professor Stuart Harding, who's usually at the interview, is very welcoming too. He won't bite. So if you're interested in this, get on board with it because a lot of people are asking. Okay. So I'm just going to answer a few questions. So yeah, okay. Look, putting that aside, bootcamp. Let's get some people there. Get involved. Get started. There's no point sort of faffing around. Oh, I'm going to. Yes, I'm going to. But there's a but and a but and a but. You want to just get on with it. The bootcamp is costing next to nothing. You're getting your CPD hours, even if you just come for that. Okay, 12-hour CPD for $300 or so if two of you come, because it's $595 for one and $595 for two. So it's bring a friend, buy one get one free. Just get on with it. If you want to start that implant journey, you just want to even start learning, come and have some fun, come and meet some people, come and see some things. Okay. Okay. Questions, answers. Brand name for membrane. I use a number of membranes. So the PTFE one. I forget the PTFE one, but I like using Jason membrane. Okay. They're going through re-TGA because they changed their sort of supplier. Nothing wrong with the membrane. What else do I like using? The xenografts, I like using the one from Straumann, but I also like using the one from BioHorizons, which has bone morphogenic proteins in it. So those are the two I like there. The membrane, as I said, was there, but the allograft I like using is called Puros. So Puros is from Zimmer. I quite like their membrane too, the collagen one, but if I had to choose a membrane, my favorite one is either the Mecoderm or the Jason membrane by Straumann. In the complications case with the occlusal issue and the bone loss, what could have been done to avoid this? Okay, that's a very good question. Look, the first thing is a sort of list of things for occlusion. I won't go into sort of too heavily, but there's a list of things. The first thing is that you've got to have anterior holding stops. So you've got to make sure the occlusion is balanced, okay? You've got to make sure the anterior function is in harmony with the enveloper function. And there's a way of doing that, okay, with using bite paper. Now we can use T-scan. You can always use scanners as well to do that. And you've got to check for lack of interferences in the excursion, the working side, non-working side. They're your basics, the stuff that you've learned. In those cases where you've had that bone loss from occlusal trauma, you check for bruxism. You try and make the restoration the same sort of size as the other teeth or slightly smaller, so you decrease the occlusal load. And then you've got to place an implant that's sufficiently sized in the right position, so it's acting axially right underneath that. So they're the main things that I would do. Okay. So I've just gone over the courses. So Peter's asked if you wondered if I could ask some questions about the courses and the boot camps. So I've described the certified courses, but the most immediate thing at the moment is the fact that the webinar's ongoing. You can come into the surgery and there's the boot camp. I'd like to see a lot of people there because it's going to be fun. We've also got a few people supporting it. There are some offers as well. And people that turn up to boot camp come to boot camp. There are some other really exciting offers too. And there's some early birds on a few other courses. There's early birds on equipment, implants, getting yourself set up, but also on the certification diploma and the master's degree. So it's a great idea for everybody to come in and have a look. The last thing was with this PTFE suture, which one do I use? I'll get back to you. I've totally forgotten the name. The suture and the PTFE membrane is the, Cytoplast. That's it. Okay, Cytoplast is the one that I use. Sorry, I use it so often. I use it every day. I don't often, I tend to forget what I'm using. And that, yeah, Cytoplus, great. That's ready available. Salvin I use for a lot of my stuff too. But that's sort of my main stock stuff. If you need to know more about it, you want to come and have a look at the array of equipment or things that we do for a setup, come and have a look. With the templates that you'd have got for the last webinar, you'll also see that you've got a number of setouts and setups for surgical, but you also need to see, you want to get refined on how to set up surgically properly, with a surgical setup, and you want to have that for your nurses or anything else, please come along. We're more than happy to help you. Okay, I am going to say goodbye for now. It's been a pleasure. This is the 4th and last webinar of the 4 set, but don't think there aren't more webinars. So we will send, make sure you follow us on Instagram, follow us on Facebook as the Education Institute, and look out for all the other things that are happening. And I look forward to seeing you soon, and hopefully I'll see most of you at the boot camp. I'll see you at the next webinar. Sorry, I think I'm just going to quickly just check. Okay, yeah, no, just all thank yous. Take care and bye-bye.